and welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Rachel Breitster, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluations at the close of today's program. Continuing education credits are available after you complete our short post-test, and your feedback is helpful in planning future programs. We encourage you to please let us know what topics are of interest to you and how we can best meet your needs. As for today's program, we will be taking your questions throughout the hour by phone. Our toll-free number is 1-800-452-0662, or you can email us at any time throughout the hour at phlive.ny@gmail.com. Today's program is Work-Related Asthma, Recognition and Diagnosis. Our guest is Dr. John May, the Director of the New York Center for Agricultural Medicine and Health, Director of the Northeast Center for Agriculture and Occupational Health, and the Director of the Bassett Research Institute. Thank you so much for being here today.
Thanks for inviting me.
Sure. So we have a lot that we're going to cover today, and I know you have a wealth of experience to share with us. So would you start off just by painting a picture and giving us an example of what an occupational asthma or a work-related asthma case might look like?
Sure. I'll tell you about a fellow that I saw about 5 years ago, a young man who had minor smoking history, and he came in to see me because he had had about 3 years of increasing chest congestion. And in the year preceding his visit with me, it had become worse. He'd had several visits to the emergency room where he received inhaled bronchodilators and felt better. And in talking to him, he tended to relate some of these symptoms to his workplace, to when he was at work. He noted that he got better when he breathed fresh air, when he used his asthma inhaler, and he also noticed that when he was on layoff from work, typically in the summers, his job would stop for a week or two, he would get better. His job involved using a respirator, and despite that, he still had exposure to dust that contained enzymes. He'd been on the job for about 5 years.
So you as a physician are seeing this patient. When you're looking at the big picture, what are the things that tell you this might not just be asthma, but this is actually work-related asthma?
Well, I think there's a couple of clues in the story that I just told you, and one was that he himself felt that his problems were a little bit worse when he was in the workplace, and particularly when he was laid off during the summer times, his symptoms did get substantially better. And then the final clue is that the dust that he's working with contains enzymes, and we'll see that that's an issue.
So certainly there are symptoms or signs that a physician might see that point to occupational asthma, but how large of a population are we really talking about? Is it worth it for physicians to get invested in learning about this?
Well, I think we're learning, Rachel, that it's a bigger population than we thought, and at this point we recognize that probably about 10 to 15% of adult-onset asthma is occupational asthma. Occupational asthma means they didn't have asthma, they started on the job, now they've got asthma. And another 10 or 20% or even more is what we call work-exacerbated asthma, which is asthma that people had, but when they're in the workplace, it seems to consistently get worse. So 25% or more of adult-onset asthma may well relate to something going on in the workplace.
Sure. So how do these work-related asthma cases compare to non-work-related asthma?
These guys can have tough asthma. It can be very difficult. They miss time at work. It interferes with their life. They have more symptoms. They have more medical costs. They spend more money on medications. And we know that if they continue with that exposure in the workplace, that there's a good likelihood the asthma is going to get worse. And on the other hand, we know that if they leave the job, many of them will have significant financial difficulty as a result of that. So it's a stress on their life. It lowers the quality of their life. And then there's this totally unrelated topic of the fact that if this person sitting here is getting sick from the job, what about the person sitting here or the person sitting there? So there's a public health aspect about the health of their coworkers that we need to worry about as well.
Sure. And is there more than one type of work-related asthma, or does it tend to look the same across the board?
Work-related asthma is really kind of a wastebasket term, or we're lumping together a series of different disease entities that have somewhat different mechanisms and different behaviors. The largest of those would be occupational asthma, new onset asthma that occurs in the workplace, and much of that relates to immunologic sensitization to something in the workplace. Some of it relates to just a direct irritant effect on the workplace. And then, as I mentioned, some of this relates to asthma that pre-existed but got worse in the workplace.
So can you give us a sense of the big picture and how these different types or categories of work-related asthma relate to one another?
Yes, and I think there's a figure that shows the universe of work-related asthma and shows the relative importance of the relative prevalence of the different entities, so that work-related asthma consists of occupational asthma, which is about 80%, and the work-exacerbated asthma, which is about 19%. And of the occupational asthma, you can see that the majority of it relates to this immunologic sensitization. Smaller proportion relates to the irritant phenomena.
So looking at that 19% that you referenced, that work-exacerbated asthma, how would you diagnose that, or specifically, what kind of symptoms would you be looking for as a provider?
Well, the key is really to establish that the person had asthma before they were exposed in the workplace, and then if they have a history of consistently getting worse when they're in the workplace, and if there are conditions in the workplace that might be expected to make their asthma worse, all of those are suggestive that this is work-exacerbated asthma. The key thing is to try to be sure that this is not asthma that started due to a workplace exposure.
And what are some of the factors that can really exacerbate one's asthma in the workplace?
You know, any of us who deal with asthmatics know that once the airway starts to get inflamed, there's really a world full of things that will stimulate the airway. And the list really includes cleaning products and bleaches. The chlorine that people are exposed to can trigger their airways. There's a variety of smokes, from cigarette smoke to welding smoke, fumes that can do it. A number of chemicals we'll see as the discussion goes on that can provoke this dust. So inorganic dust or organic dusts can provoke it. A number of indoor air pollutants, so that we see office workers or teachers and problems that have problems with molds or materials that are in the air conditioning systems.
So certainly there's a number of different stimuli that exacerbate the condition. Does that mean there are certain occupations or professions that are at greater risk of developing this work-exacerbated asthma?
There are some that really kind of trigger you right away. If, for example, somebody is a laboratory technician working with rodents, we know that there's a high risk for those folks. Certainly, people who are exposed to smoke, firefighters, welders are at risk. I've mentioned the risk associated with cleaning materials and bleaches. People exposed to wood dust can have reactivity. Organic dust, people working in waste handling, and certainly people working in agriculture have lots of exposure to organic dusts. And then there's a variety of other things. And again, indoor air can affect office workers and teachers and be a problem as well.
Now, so far we've been talking mostly about this work-exacerbated asthma, but you mentioned that other large percentage of occupational asthma. So can you talk a little bit about that?
Sure. Occupational asthma is really an interesting problem for those of us in the field. And again, it is the majority of it relates to immunologic sensitization, and some of it relates to irritation.
And there are different kinds of material in the workplace that can cause a different kind of response in terms of occupational asthma?
There are, and we tend, again, to lump these into high molecular weight substances, which are complex proteins or polysaccharides or polypeptides, usually of either animal or plant or bacterial origin. So here we're talking about things like proteins from laboratory animals, okay, proteins from crabs and other seafoods. Bacterial enzymes are used in a lot of production. So these are complex, high molecular weight materials, and the individual can become sensitized to these generally over a period of a couple of years, so that initially the person is in the workplace, and then at some point they become sensitized. They begin to develop antibodies to this, usually what we call immunoglobulin E, which is kind of an immediate reacting antibody. And at some point after that has begun to appear in the person's system, they'll notice when they go into work they're having a little bit of runny nose and drippy eyes. And then usually within a year of the onset of the nasal symptoms, people will begin to develop some airway symptoms, so they'll begin to have asthma. Less common is reactivity to low molecular weight compounds. These are often chemicals, too small to really result in immunologic sensitization on their own, but they bind with albumin or other proteins in the blood, and then the person becomes sensitized, oftentimes not with immunoglobulin E. So examples of these would be isocyanates, a chemical that's used for plasticizing and for paint hardening, so people in auto body shops can have problems with that. Certain metals like nickel and platinum can cause problems. Drugs like penicillin and tetracycline are examples of low molecular weight. And then there's this, and the latency period for the low molecular weight agents is a little bit longer. Mm-hmm. And again, there's a wide spectrum here, but the tendency is that these would be a little bit longer. And then there is this other phenomena of asthma that comes on with no latency at all.
And talk to me about reactive airway deficiency syndrome. Is that something that you've seen, and what does that look like?
It's called RADS because most of us can't get that mouthful out. And I'll just tell you about a patient that I saw 20 years ago. And at the time, he was a remarkably fit marathon runner with no history of asthma at all. He worked in an aluminum smelting plant. And one day on the job, he had a big rubber mallet in his hand that he inadvertently dropped into a pool of molten aluminum. And as he sort of reached to try and grab it, a big bubble came up in this pool and popped open, and he inhaled whatever smoke or fumes came out of it and immediately felt his airways tightening up. And that night, rather than go home, he drove to the emergency room. Mm-hmm. They gave him inhaled bronchodilators. He felt better, but this is 20 years ago, every day since then, he has had some degree or another of reactive airways disease.
That is a very startling kind of picture you paint. It certainly sounds like a very serious situation. So can you talk to us about what exactly is RADS, meaning what happens in the body?
Well, I would say that we don't understand exactly, but something, it's typically a big dose of a very irritating inhaled material that injures the airways, and people develop symptoms of asthma almost immediately. And oftentimes we can see that if we bring them into the pulmonary function lab and do what we call spirometry of forced exhalation, we can see that they have problems. But sometimes with spirometry and asthma, the test can be entirely normal. And in that situation, we can challenge people and demonstrate that they have this nonspecific airway reactivity.
And so in that situation, it was an immediate reaction. He breathed it in. He felt his lungs constricting. Are all incidents of irritant-induced asthma, do they all have an immediate onset of symptoms?
Well, that's what we have thought for years. And I think in recent years, we've begun to realize that there are certain job classifications where there are significantly high rates of asthma. So people who work in custodial work, people who work as maids in hotels, and it turns out that these people are exposed to cleaning products, to ammonia, to chlorine, oftentimes in concentrations that are higher than are permitted in industry, and they may be exposed to this multiple times a day for years on end. And as time goes on, the airways get progressively more irritated, and so it turns out that there's sort of a chronic component to this irritant-induced asthma as well.
So you've provided a lot of information about what sorts of things are the stimuli and who might be at greater risk. Can you talk to us about how does a provider know when to take the next steps? If you're working with a patient, what's the trigger to you that you need to look into this a little bit further?
Well, I think anybody who has adult onset asthma that's proving to be difficult. So if you've got an asthmatic who's a troublemaker and you're just not really getting control of the situation, then usually what we try to do is think about what's going on in the environment that could be a problem. And typically we think of the home environment when we try to count the number of cats, and is there mold in the basement, and is there a wood-burning stove? And we don't often think about the fact that people spend a third of their life in the workplace and don't inquire about what could be going on in the workplace.
And so for providers who maybe are not as familiar as you are with work-related asthma or occupational asthma, what sort of hints or insights would you give them to help them with diagnosis and treatment?
Well, I think probably the key hint is this phenomena of having more symptoms during the work week, having less symptoms on weekends, and having improvement on vacation times. I think it's a really strong hint that something's going on. And then I think as you learn more about what the patient's job is, and if it's a job in which there are substances that are being either aerosolized, or if there's smokes or fumes in the workplace, you have to be suspicious.
Sure. And what are some of the more commonly reported causes that you see?
There's a huge long list of things, but some of the ones that are commonly seen are diisocyanates, which I mentioned before. These are low molecular weight chemicals that are used oftentimes in spray paints to kind of harden the paint, and people can be exposed to those. A number of aldehydes, so formaldehyde, glutaraldehyde, people are oftentimes exposed to those in a wide variety of processes. One of the highest rates of sensitization is people who work with snow crabs, and so people who work with seafood proteins are at risk. Wood dusts can certainly trigger it, and we all know that people can become sensitized to latex. Various enzymes are used in a lot of products. These days they are usually encapsulated so that people don't react, but if the enzymes are not adequately encapsulated, they can react to that. And various other chemicals and anhydrides are used as accelerants in a number of chemical processes, and those can cause problems as well.
And what about being aware if a person maybe starts to see some relief in their symptoms, but then the symptoms start coming back when they're re-exposed to the irritant? Is that something to be aware of as well?
Yeah, that should really perk your ears up. I think if somebody's away from the workplace for one reason or another, they're doing better, and then they go back in the workplace and things get worse. Very suggestive, I think. I think that one thing that sometimes as clinicians we don't always think about, and certainly patients don't, is that the reaction to these materials can be what we call biphasic, or there can be two phases of it. And typically people will get, particularly to high molecular weight agents, will get an immediate reaction when they're in the workplace, and then later in the day or in the evening they may suddenly tighten up again, and they're trying to figure out what is it that did it. Well, it was the exposure earlier in the day. And in some cases with low molecular weight agents, they don't even get that immediate response. It's just 8 hours later they're responding to something. It's really hard to put it together sometimes.
Yeah, that seems like it could be very challenging.
Mm-hmm.
Now, what factors might increase the risk for sensitization and occupational asthma?
Several factors have been identified. Some of these relate to the workplace. Mm-hmm. So we know that certain agents are more likely to sensitize people than others. And obviously in some workplaces there's either consistently greater exposure, or there are peaks of exposure, and so that could influence the rate at which people become sensitized. And then there's some personal phenomena as well, so that people who have atopy, so people who tend to get allergies and eczema, are more likely to get sensitized. People who have certain genetic predispositions can be more likely to become sensitized. And then cigarette smoking is a factor both in terms of heightening the risk of sensitization and then heightening the likelihood that the sensitized person will go on to develop asthma.
So let's talk about diagnosis. What steps should a healthcare provider take towards making a diagnosis of occupational or work-related asthma?
this is an important diagnosis to get right because it has legal and financial and social implications that are quite substantial for patients. So I think we try to do it in a stepwise fashion, and the first step is to try to be sure that this person actually has asthma. There are other disease processes that can sometimes mimic asthma, so we want to be sure that they've got asthma. Then we want to try to look at the workplace and see, are there substances in the workplace that we know can give people asthma that have been established as asthmagens. And then if we know that somebody's got asthma and we know that there's something in the workplace, can we actually show that there's really a relationship? So there's really kind of 3 phases of this that we have to go through.
So let's start by taking a closer look at that first phase. You said the first question is to sort of establish, is this really asthma? What do you need to look at to make that diagnosis accurately?
We rely on history a lot, and there are some pros and cons to the history, but we rely on it a lot for asthma. We oftentimes can be helped with pulmonary function testing. So if we bring the person into the laboratory and have a forced exhalation, a lot of times we can see evidence that the airways are constricted and the air comes out more slowly than we would expect. But one of the characteristics of asthma is that sometimes they'll go into the pulmonary lab and have perfectly normal pulmonary function. And in those situations, we oftentimes rely on some other testing that I'll get into in a few minutes here.
So when you talk about you rely fairly heavily on the patient history, what parts of a patient history are really important to take note of?
There have been some studies looking at the various questions that we ask people about asthma to try to identify which ones are most helpful in terms of work-related asthma. And it turns out that this business of getting better when you're away from work and getting worse when you are in work is probably the most sensitive test. The thing that's a little bit tricky about that is that as the disease goes on and the airways get more and more inflamed, they may not actually get very much better in 1 or 2 days on a weekend. So early in the disease, weekends can help. Later in the disease, we really need to see what happens when they're out of work for a number of days. So that's a good question to ask. It is very sensitive, not terribly specific. Wheezing at work is more specific, and so the combination of those two is pretty helpful. For people who have high molecular weight sensitization, the phenomena of getting drippy eyes and runny nose when you enter the workplace is very suggestive.
Now, you mentioned using spirometry as a means of testing for asthma. What other kinds of tests can be done to assess whether or not a person is suffering from asthma?
Well, the key phenomena of asthma is that the airways are just a lot more sensitive, a lot more inclined to want to constrict in the asthmatic than in the normal person. So if somebody's spirometry is normal, what we will do sometimes is try to stimulate the airways, and we can do this with a substance called methacholine or histamine. You can even use cold air. A variety of substances can be used, but basically what we try to do is bring them into the laboratory and measure how much air comes out in the first 1 second. We call that the FEV1. And whatever amount comes out, that becomes the baseline.
Okay.
And then what we're looking for is what dose of methacholine do we administer before there is a 20% fall in FEV1. And for people who don't have asthma, it's a pretty high dose. And for people who have bronchial hyperreactivity, it's a pretty low dose. And usually it's very helpful in terms of separating the two.
Great, thank you. So we established that somebody has asthma. Then that next question you said in your stepwise approach is identifying, are there asthmagens in the workplace? Can you talk about what goes into that step?
That's when you actually have to sit and listen to the patient. Something we don't do very well, but it's an opportunity to learn what job the person does and have them describe to you the workplace. Is it a workplace where when they walk in every morning there's dust all over the place? Are there fumes or dust being generated immediately next to them? What's the ventilation system like? Have they been given a respirator to use on the job? Do they ever use the respirator? All of these, I think, are considerations. The employee can bring in a safety data sheet that lists all of the different materials that are used in the workplace, and you can go online and look those up and see if any of them have been linked with asthma in the past. I think the gold standard here is to call in the pros, and I think if you have access to industrial hygiene expertise, those folks can come in and look at the workplace in a very systematic fashion and be enormously helpful.
Great. Now, having access to an industrial hygienist can certainly help with this process, and we met with Nick Pavelchuk, an industrial hygienist at the New York State Department of Health, to get a better idea of what his office does and their role in addressing occupational asthma.
I am the Chief of Intervention, Outreach, and Prevention for the Bureau of Occupational Health and Injury Prevention, and we provide industrial hygiene services to employers, workers, also technical assistance to physicians. Industrial hygiene is a science that's devoted to the anticipation, the identification, the measurement, evaluation, and control of hazards in the workplace, including occupational asthmagens. We know of over 300 substances that can cause or aggravate asthma. Many of these are used in the workplace, everything from isocyanates to simple cleaning products. Some examples of workers at risk for occupational asthma are custodians who handle a wide variety of chemicals. Often they handle them in concentrated forms and have to dilute them in order to use them properly. They often use them in poorly ventilated, enclosed spaces as well. Another example are hairdressers who can have exposure through skin contact as well as inhalation, such as to formaldehyde, which is a key ingredient in many hair smoothing products. These occupations are not generally considered to be hazardous by the general public, but in these occupations they do handle a wide variety of chemicals, and there are also many workers within these industries. The way we control hazards in the workplace is that regardless of the occupation, there are basic principles that we follow, and these are commonly referred to as the hierarchy of controls. And these controls include product substitution, engineering controls, administrative controls, work practice controls, and at the bottom of the list is personal protective equipment. And these controls are listed in descending order of effectiveness because as you go down the list, they require more direct human intervention in order to be effective. The first thing we look at is, can we substitute the product that the worker is using for something that is less hazardous? What people often rely on is the one on the bottom of the list, which is personal protective equipment, including respirator masks. These are really a last resort measure. They are the least effective way to protect a worker, and so they should only be considered when other control measures are either inadequate or just not feasible. Here at the New York State Department of Health, we provide a wide variety of technical services and assistance to employers, workers, as well as physicians in all aspects of occupational health and safety, including on work-related asthma. Some of this work is done by telephone call, so you can simply just give us a call and we could provide assistance to you. In situations where it's warranted, we will actually go on site using scientific equipment to quantitatively measure exposures in the workplace, to evaluate the work practices, and to develop control measures for the employer. The goal of our industrial hygiene work here at the Department of Health is twofold. The first is we want to reduce or eliminate exposure to the worker who was diagnosed with occupational asthma so that that person can continue to have a productive career. The second aspect is once we know that there is an occupational asthmagen in a workplace, we want to protect the other workers from having exposure and developing occupational disease.
So Nick mentioned that there's quite a few different agents that can exacerbate asthma, and we're still talking about that second question of identifying, are there asthmagens in the workplace? So how many different agents would you say we're talking about, and how can people find out about what these different agents are?
There's a system that has been devised that looks at agents very specifically and very specific criteria that have to be met before something is categorized as an asthmagen. At this point, there are probably approaching 300 of these that have been identified, and I'm showing basically the same website that Nick cited, and it's very handy. You go in, just type in the agent, and it will tell you, either give it a thumbs up or a thumbs down.
All right. So finally, looking at that third question in the steps to diagnosis, how do we demonstrate a relationship?
Well, that can be kind of tricky sometimes, and the best way is once you've identified the suspect agent, if you take the patient and the agent and put them together in an exposure booth and just gradually increase the amount of exposure that the person gets and follow what's happening with their lung function tests, you can do a specific challenge, and that's a really very helpful test that can be done in maybe 5 places in North America. So it's a great test, but we never do it.
Sure.
What we do know is that people who do have those positive tests also have increased numbers of eosinophils, a certain type of inflammatory cell, in their sputum. And so that may prove to be a useful helpful test as well. The tests that we use, I think, most at this point are symptom diaries combined with peak flow measurements. Another approach that can be used is, we talked about the methylcholine challenge and the fact that when the airways are irritated, people respond at relatively low doses. Well, if you pull somebody out of the job for a month or 2 and then repeat that test, you might find that it takes a much higher dose of methylcholine to get them to respond. So that can sometimes be helpful as well.
Now, one of the things you mentioned was the peak flow metering. What is a peak flow, and how do you measure it?
So a peak flow meter generally costs $15 or $20, and people can be taught pretty easily how to use it. There's a mouthpiece on it. They just fill their lungs up completely, put it in their mouth, and blow out as hard and fast as they can. And when they do, there's a little thing that pops up, and they can record that number and put it on a little chart that we give them so that they plot out. And if they do this 4 times a day and faithfully plot out the pattern, and we know that about 70% of people will actually be able to do this, and they'll actually bring in data that's useful at the end of a couple of weeks, you have a pretty sensitive and specific test. And really what we look for are the patterns of peak flow. So nobody blows the same flow all the time, so there's always kind of a sawtooth pattern. But if the pattern on weekends shifts up and the peak flows are higher, and then when they go back to work it goes down again, and certainly if they take a week off for vacation, it's really helpful if they're consistently higher and then they go back to work and they are lower. It's very helpful information. There are computer programs available to analyze these, and sometimes people will look at the actual extent of the deviation. There's a number of different ways, but oftentimes you can just sort of eyeball this and correlate it with symptom diaries and when they were at work and when they weren't, and it's pretty useful.
Great. Now, are there any other allergens that you would recommend testing for?
There are some commercial allergy tests that can be really, again, what we're trying to do is, this guy's got asthma, here's the substance, is there a relationship? And in a small number of cases, relative to the 300 agents that can do this, a small number of them, we can actually do skin testing, or we can draw blood and see if they have antibodies to these particular agents. And so those tests are really helpful when they're available, but most of the time they're not available.
So we've talked an awful lot about the work-related asthma and the risk factors. Can you summarize for us what we need to remember in terms of coming to a diagnosis?
Certainly, and again, it's important to get this right. Have to be sure that it's really asthma. Have to be sure that there is something that has been documented as an asthmagen that's in the workplace, and then we have to go through these various efforts to try to relate the two.
Now, being sure that it's really asthma, being sure that it's related, the work-related, to the asthma diagnosis, talk to us about differential diagnosis.
Well, probably the leading thing for occupational asthma in the differential diagnosis is just asthma that's not occupational. But when we think about asthma in general, we need to think about a variety of other things that can cause similar symptoms. So that various types of bronchitis, people can get bronchitis from smoking or from industrial exposures. can mimic the symptoms. People can get a problem called hypersensitivity pneumonitis in the workplace that can mimic the symptoms. In certain specific exposures, like cutting certain types of metals, people can get sick and have asthma-like symptoms. There's this other phenomena called vocal cord dysfunction. When people have asthma, the obstruction to airflow is in the chest. When people have vocal cord dysfunction, the obstruction is in the voice box. It would seem that you could sort those out pretty easily, but you can't.
Okay.
And so that it has to be kept in mind, and it can be tricky to sort that out.
So certainly not necessarily an easy thing to diagnose, but let's assume that we take the steps, we're able to make the diagnosis. Let's bring this full circle and talk about how do you treat this, and better than that, how do we prevent this from happening?
So treatment is not substantially different than we would do with any other type of asthma. These people generally have more difficult asthma, and so typically they are on a long-acting inhaled bronchodilator, and usually that's in combination with some inhaled steroids. Inhaled corticosteroids are probably an important component of this no matter what. And there may be some other agents that are used to help control the asthma symptoms as well. I think one of the things that's important is that if the patient chooses to remain on the job and has ongoing exposure to whatever it is that's making the asthma more problematic, we have to realize that in some cases the asthma will just sort of smolder along. In other cases, the asthma will get progressively worse and worse. And so it's important that we be monitoring these people on a periodic basis so that if somebody is getting into progressively more and more trouble with the asthma, we can sit and talk about that, and the patient can make an informed decision about what it is that they want to do. I think the other part of this is some of the things that Nick touched on in his discussion, and that is that there are a number of things that can be done in the workplace, and the best of these is just to take the incriminated substance out and substitute it with something that might work just as well. But there are issues in terms of how to ventilate the workplace, how to isolate some processes from where the workers are. People always receive respiratory protection, and it's not one of the things that works very well. Other approaches that can be taken if the workplace is big enough, and depending on the skills of the individual worker, it can be that they can be reassigned to some task that's unrelated to the exposure that's causing problems for them. The issue of leaving work always has to be considered at some point, and it's a tricky one in that we know that if somebody is diagnosed early and leaves the workplace, in many cases, in about 30% of cases, the asthma can go away completely. In the remaining 70% of cases, the asthma can be much more readily controlled than if they stay in the workplace. We also know that there are some financial disincentives to leaving the workplace. There are considerations in terms of disability, workers' comp, vocational rehab that have to be considered in all of this. And again, as was mentioned, we need to keep in mind the threat to other coworkers as well.
Sure. So with treatment, what can you expect in terms of outcomes?
If people leave the workplace, some of them will do quite well. But we know that when people leave the workplace, probably 60% or more of them will have financial hardship related to that. So it's kind of a two-edged sword, and the decision is usually one that the patient and the family need to make, and it's a difficult one. I think in general, this problem has a lot of impact on patients, and people get angry and depressed and anxious about this, and all with good reason. They're facing the loss of employment. Sometimes it's not so easy to go back and get another job. And they have a whole new set of health concerns that they never had before.
So certainly that ties into a whole other section of public health concerns to be aware of.
Right. Right.
So going back to that original chart that we started off with, this really is a pretty large-scale problem then that we're talking about. Would you agree with that?
It is, and I think 25% of workers, and the number certainly could be larger than that. Most of these with new onset asthma that has occurred in the workplace either because of immunologic or irritation issues in the airways. And then a smaller proportion of people who have asthma, but it gets consistently worse when they're exposed in the workplace.
So in looking then at the role of physicians in diagnosing and treating and prevention, how many physicians would you say are skilled enough or aware enough to be asking the right questions to identify this 25% that we're talking about?
As clinicians, we don't do a great job with this. And just at the end here, I'll show you a paper that was published a few years ago from a VA hospital system in California. And they had roughly 200 patients who had been discharged with newly diagnosed asthma. They simply pulled the charts out and looked at how well documented the investigation of their asthma was. And what they found was that in about 3/4 of cases, people had actually identified the job classification. So 58-year-old mechanic, 32-year-old homemaker, that was documented. Mm-hmm. In about 1 in 5, there was any evidence of even further consideration of the workplace. In only about 4% of these was there really very much detail. So the sort of detail that I talked about in the very beginning, only about 4% of these was there enough detail to really think intelligently about the workplace. 2% of these people, so out of 200 people, 4 were diagnosed with occupational asthma or work-related asthma. We would expect, as we have seen, we would expect that 40 or 50 of those people would have been diagnosed with work-related asthma. So as clinicians, we're not doing such a great job. And I think that if a clinician simply asks a couple of key questions and has a suspicion and then turns around and refers that patient to somebody with appropriate pulmonary or occupational expertise, that clinician is functioning at a level higher than 90% of their peers.
So in recognizing then that we need more information, clinicians need to be doing a little bit more to make this diagnosis, where can they go to find out more information? What's a resource for our viewers?
Well, here in New York, we're fortunate in that the Department of Health has a great resource. There is a system of occupational health clinics that are staffed by physicians and nurses who have occupational expertise. They have industrial hygienists. They have social workers who can provide support and help steer families and patients through this tricky situation. People can read more about this on the Department of Health website if they look for environment and workplace. These clinics are located across New York, really from Long Island to Buffalo. So I would suggest that if people have a patient and they're wondering if this could be occupational, the easiest way to get it answered is to figure out where is your nearest occupational health clinic and send the patient off for an evaluation.
So there are certainly resources out there.
There are.
Absolutely, great. So now it is great to know that in New York State we have so many resources available, and we know that the New York State Department of Health, the Center for Environmental Health, is also very involved in trying to identify and address this problem as well. Let's go to Dr. Nathan Graber, the Director of the Center for Environmental Health, to hear from him about the importance of this issue and the work being done to address it. So Nathan, we're talking today about the recognition and diagnosis of work-related asthma. Can you tell me about the role of the Department of Health in that program?
One of the core functions of the health department is something called surveillance. Surveillance is a systematic collection of data, and it's not just about collecting the data, it's also about analyzing that data and using that to provide information for preventing those conditions in the first place. And for work-related asthma, we actually have two kinds of surveillance that we conduct here at the health department. Mm-hmm. One of them is a sort of population-based surveillance, which is we have actually a couple of questions in what's called the Behavioral Risk Factor Surveillance Survey, which is a statewide survey that collects data on the population as a whole and asks questions specifically about asthma. then we had an opportunity to actually go back and ask some of those people about whether or not their workplace helped contribute to that asthma. So it turns out 45% of working adults actually have something in their work environment that makes their asthma worse.
45 is a really large percentage. That's actually very surprising to me. Does the survey collect any data about what kinds of things might be contributing to that asthma?
Well, actually, until last year, we were only able to find out just sort of basic information about whether or not it was the workplace that was contributing to their asthma. And last year, we were able to add a couple of questions about sort of the industry or type of work that they do. But it's not very detailed information. And that's why we have the second kind of surveillance, and that's case-based surveillance. Case-based surveillance is where we actually go back and speak to patients who've been diagnosed with asthma that's related to their work to find out more about the places that they work, the type of work that they do, and the potential exposures that can be worsening their asthma. Unfortunately, our case-based surveillance, we don't get a lot of reports. So we don't get enough information about work-related asthma across the state.
And so why is it that only a small portion is being identified, that you're not getting these reports?
Well, there are a lot of different reasons. Let's start with just the patient themselves. So they're in the workplace and they have an asthma, they have some trouble breathing. Not everybody's going to actually go to the doctor for that because maybe it gets better when they go home. And so they say, oh, I'm okay. I don't, it just happens at work. I'll be okay. I don't need to go to the doctor. And for those patients who actually make it to the doctor, it's not always the case that they're diagnosed with asthma. It may be that they're diagnosed with some kind of reactive airway disease or some kind of chronic cough, but not necessarily get that diagnosis of asthma. Once they have that diagnosis of asthma, it's up to the healthcare provider to actually ask the question, well, is there some place where this asthma gets worse and other places where it's better? And if they ask that question, they might find out that it's actually the workplace that it's taking place. So once they find out that it's the workplace that is contributing to their asthma, then they have to know to report.
And what are some of the perceived barriers to reporting?
Well, one of the problems, and I just was about to lead into this, is that actually a lot of providers don't know that they need to report. There's a very long list of reportable conditions the New York State Department of Health has, as well as some local health departments, which is even more comprehensive than ours. And so physicians need to know that this is one of the reportable conditions on that list. And once they know that they're supposed to report, they have to feel comfortable doing it. And sometimes they're not, especially when it comes to work-related issues, because they might be concerned about the patient themselves and whether or not they might get in trouble at work, or it might be some kind of retribution for having reported their workplace as being a problem. And then there's also just the classic problem that all physicians have, which is just time. The amount of time it takes out of their schedule, the resources for themselves or their office staff to actually do that reporting.
Now, what about concerns regarding HIPAA? If physicians are mandated to report this information, might they have concerns about violation of client confidentiality and how that might interact with HIPAA regulations?
Right, so that is a very common question regarding reporting in general. And actually, HIPAA expressly states that for the purposes of public health surveillance, physicians can report to local health authorities or state health authorities without actually getting specific permission from the patient themselves.
So how does, once we've overachieved these barriers to doctors reporting or not reporting, how do they go about then making that report?
Well, there are a couple of different options. So before we even get to exactly how to do it, it's important that the physician understands what we're going to be asking about. So the information that we need from the healthcare provider includes the patient demographics, some information about the clinical evaluation, and the results of any diagnostic tests that were done. Once they have that all together, you can either go to the website and download one of our reporting forms, fill that out, and then fax it to the state health department. Or they can just pick up the phone and call, and somebody will take that information over the phone.
So I would imagine that another potential concern would be, what are you guys doing with this information after you've received the report? So can you talk about what it is that you do?
Right, and that's really important, because it's important that physicians understand how we use that information, and maybe that'll actually encourage more reporting.
Sure.
Because we really can't learn enough about occupational asthma without speaking to the patients who experience the workplace exposures and the symptoms of asthma. So once we get that information, we may have to call back the doctor once in a while just to confirm some of the information, but most of the time there's enough information in the report, and we call the cases and we discuss with them their asthma, what are some of the triggers that they experience, whether or not they're taking place in the workplace, and if they are taking place in the workplace, then what are some of the conditions? What kind of work did they do? What are some of the protective measures that are in place? And then we take that opportunity to educate them on what they can do to reduce their own exposures, and then we'll ask them if it's okay for them to if it's okay with them for us to contact their employer and talk about additional ways that we can address the exposures that are triggering the patient's asthma.
Great. And are there resources available that might help healthcare providers when talking about patients or working with patients who have work-related asthma?
Absolutely. And one of the greatest resources we have here in New York State are the occupational health clinics. There are a network of clinics across the state, and they're staffed by physicians who are specifically board certified in occupational environmental medicine, along with other health professional staff, including industrial hygienists. Industrial hygienists are a group of professionals who focus on workplace exposures and safety hazards and the ways to evaluate them and to address them to protect workers. And so in addition, we at the State Health Department, we also have those kind of, we have industrial hygienists as well who can also help to provide that information. We have outreach and educational material that is available on our website for anybody who can, to download.
Great. So it sounds like healthcare providers have a very important role in the recognition and diagnosis of work-related asthma. Would you agree with that statement?
Absolutely, I'd agree with that. Physicians and healthcare providers are really at the front lines. They see the patients who are experiencing asthma and worsening asthma because of conditions in their workplace. Now, public health is a partnership, and in order for us to really understand and be able to design effective prevention programs for work-related asthma, we have to get that information from physicians and the patients.
Great. Well, thank you so much for your time today. It's been great meeting with you.
It's been very nice meeting with you as well. Thank you for coming.
So we've certainly covered quite a bit of information in the hour today, and we've gotten some questions in from our audience, so hopefully we can get to some of those. The first is it necessary for workers to leave their job if they have work-related asthma?
You know, as a physician, I would say absolutely, absolutely. But the reality is that that life is a lot more complicated for people, and I certainly have patients who I have suggested to them that if they stay in the workplace, there's a good likelihood that their asthma is going to get progressively more problematic, and they'll get to a point where we're not able to treat it as well as we can now. And they have made the decision to stay in the workplace, usually for financial reasons. Mm-hmm. Sometimes it works out, and sometimes at some point later on they're forced to leave after all.
Now, the next question is, should I refer my patients who I suspect have work-related asthma to an occupational medicine specialist?
I think either an occupational medicine specialist or a pulmonary specialist would be the people to consider. And I think since we have this wonderful resource of the occupational clinics in New York, it's a really easy way to go. And I think one of the benefits of using the occupational clinic is that the clinics have resources that can not only address issues with the patient, but can hopefully address issues in the workplace.
Great. Now, just as an aside, our primary audience is New York State, but do you know if there are occupational health clinics throughout the country as well, or is that outside of your?
New York is really unique
okay.
in having this. There are a couple of other states that have this capability and to a very limited degree, but to have an entire network across the state, to my knowledge, New York is unique.
Okay. How about if my patient does not show improvement on the weekends, does it mean their asthma is not work-related?
It does not. And I think, first of all, at least a lot of the people that I meet don't always work on weeks and weekends. And so sometimes they'll have Thursday off, and then they'll have, Tuesday off the next week. And so it can be more complicated than that. And I think also If the airways are pretty inflamed, they may actually get better over the weekend, but they may not really perceive a big change in things. Early in the disease, I think people can kind of point out that weekends are better, but as the asthma becomes more problematic, it's not always so easy.
So as the disease progresses, it's going to become more difficult to make that diagnosis because you're not getting as much relief.
Right,
Okay.
right. And so you need longer periods of time away from the workplace, and so
and that's tough to get.
that's a little dicey. I work with farmers, and so when's the last time you had a day off? Well, I took an afternoon off in 2006.
Sure.
So for some people that you don't have the luxury of having that even.
Okay. And we have one more question. This says, many people who are working in the service industry may represent different ethnic minorities with no health insurance. How do we identify these cases and make sure we provide them with treatment?
So that's a tough question.
Sure.
But I think in terms of identifying the cases, we know that people who work in custodial jobs, people who work around bleaches, cleaning materials, are at particular risk. And so I think that if you have a patient with that who works that kind of a job, you need to be particularly suspicious. So in terms of identifying them, I think you just have to be suspicious. In terms of the finances of their care, we all know that's a much more dicey situation. But again, this clinic network does receive state support, and I think in most cases the clinics have some flexibility in terms of the charges and in terms of reimbursement.
Great. Well, thank you so much for all the information you've shared and for taking the time to answer our viewers' questions.
It's a pleasure.
And thank you very much for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain Nurse Continuing Education Hours, CME, and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. Additional information on upcoming webcasts and relevant public health topics can also be found on our Facebook page. Don't forget to like us on Facebook to stay up to date. This webcast will be available on demand on our website within 2 weeks of today's show. Please join us for our next webcast on July 17th, Mental Health and Substance Abuse, Connecting the Dots. I'm Rachel Breidster. Thanks for joining us on Public Health Live.